Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're very glad you joined us. Before we begin, I'd like to thank our sponsor, Studio Arts and Glass, Genier Appraisals and Liquidations. Today, Brad and I are broadcasting from our administrative offices, and our very special guest is Dr. Chase Beach, DO, General Surgeon with Altman General Surgery. Good morning, Dr. Beach, and welcome to the show.
I appreciate it. Thanks for having me on.
All right. Altman General Surgery specializes in general surgery with a wide scope of procedures, including the latest in robotic-assisted surgeries for the highest level of comprehensive surgical care. State-of-the-art treatments include robotic-assisted minimally invasive procedures, colon and rectal cancer surgeries, comprehensive breast care, abdominal and gallbladder procedures, and hernia surgeries. This morning, we're going to talk with Dr. Beach about robotic surgery and other procedures provided by Altman General Surgery. We'd like to remind our listeners today that our program can be found on our podcast. Just search for Health Matters with the Medicine Center Pharmacy in your favorite podcast app.
So, Dr. Beach, welcome to the show. Tell us a little bit about yourself, your background, and your training.
Yeah, so I'm a recent grad from Western Reserve Hospital, which is a community hospital just outside of Akron and Cuyahoga Falls. Before that, I was at LECOM. It's a DO school, DO med school in Erie, Pennsylvania. And prior to that, I got my master's at Akron and my undergrad at Worcester.
So you didn't go to the Florida LECOM, huh?
No, I stayed in the cold white north.
We've had some students, pharmacy students from LECOM come in for a month or two or something like that.
Yeah, it's a pretty big program that they're expanding everywhere. I think they even have a couple other outlying locations in Pennsylvania.
Mm-hmm. So some physicians are MDs and some are DOs. Can you explain the difference? Yeah,
so a good question, and thankfully, Ohio overall is pretty DO friendly due to Ohio University and LECOM being both pretty big institutions. But other places have a little bit of a gray area and don't have a lot of DO schools. There used to be a much bigger difference 30, 40 years ago. A lot of the DOs were much more primary care oriented and took this more holistic approach on treating patients. And they still do teach that. But we've taken the DOs overall taken advantage and have been spread into other specialties, including surgical specialties like I have in general surgery. But the biggest thing that we learn that the MDs don't touch on at all is some of the manipulation techniques that we learn. Again, I don't use a whole lot of those in general surgery. Not a lot of people need their backs cracked when they're having gallbladder problems. But
hey, why not? Get it done twice.
Thing. Yeah, exactly. So that's what some of the, especially the primary care docs that are DOs can, they usually take advantage of some of that kind of stuff and the manipulation techniques that we learn.
So you alluded earlier that you are not from this area. Is that correct?
Well, I went to high school in Orlando, so a little ways away. Both my parents are originally from Ohio. They met at Ohio State, so Ohio's always been part of the family for all good reasons. And so when I looked at schools, I came up here and looked at Worcester and fell in love, and then met a girl who's from Stowe, and the rest, as they say, the rest
so
is
now
history.
You're stuck here, huh?
Yeah. And we've been in Stowe and Cuyahoga Falls ever since we graduated in 2010, and got 5 little ones at home, and are loving the chaos and living the dream.
Gosh, 5 kids! Oh my gosh!
Yeah.
What's how old are they?
My oldest is 8, 6, 4, soon to be 5, 2, and almost 3 months.
Wow. Okay.
Yeah.
Let's see. Do you ever get any sleep?
I'm being in surgery, you're kind of used to the sleep when you can, and
I guess, sure.
Yeah, and it's been 8 years worth of kids now, so between surgery, residency, and kids, I sleep when I can, and seem to do all right. Coffee helps.
Okay, I guess you're right. So where are you currently practicing? Here at the main hospital, or?
Yeah, so that's where most of my practice is located. I have at least a day and a half of office at the main campus a week, and then I just started expanding down to Dover just actually last month in January, where I'm down there for a half day every other week.
For surgery or just for office calls?
Just for office. Yeah, unfortunately, we don't have a location down there that we can perform any type of surgeries, but at least that makes it for a little easier for the folks down there, especially in this weather, for pre and post-op stuff. So
Sure.
then they only really have to come up here for the procedure, and then we can do most of the other stuff down there.
Sure. So there's a lot happening in Altman. Here we are sitting in our office, and we can look across the street and see the new cancer building. You
Yeah.
know, they're putting it together really quickly. So I understand your practice is expanding, and you are seeing patients in Dover, as you just said. What about Massillon and Orville?
Yeah, so I personally don't go over that way, but we at least I'm one of 5 others in my practice, and Dr. Lafferty and Dr. Roberts both go to Massillon. Dr. Lafferty and Dr. Visconti also both go to Orville. So we do our best to kind of spread ourselves out and provide as much care to the area as we can, especially for those folks that may not be able to easily get down to the main campus.
Is there any surgery being done over there in Massillon or Orville?
Yeah, so Massillon, no, but Orville, yes. They even have a robot down there. It's not most of the time if they need to be an overnight stay, then we bring them up to the main campus because it's tough on weekends sometimes to get out there for the doc that's on call, because we also cover trauma at the main campus. So it's just a little far away to try and round on folks down there and then come up here and cover the trauma. But for elective stuff, especially that only, outpatient procedures, gallbladders, hernias, that kind of stuff, they are doing some of that down in Orville.
Good. Okay.
So Dr. Beach, let's talk about some of the procedures you perform at Altman.
Yeah. So I consider myself a very, generalized general surgeon, which means we do a lot of different stuff from lumps and bumps and little lipomas and skin tags, to hernias, gallbladders, colon cancers, breast lesions, that kind of stuff. And then just kind of your everyday, local infections, small abscesses, and try to cover a good breadth of stuff to our community.
So let's talk about robotics. How can robotic assisted surgery help you do your job?
Yeah, so good question. And for someone like me, I actually didn't get a ton of exposure to it in training because I came from a smaller hospital. Those robotic machines are a little pricey, so our facility couldn't afford it. But as I got into practice here, I got much more exposure to it. So most of my training was with laparoscopy, which is similar, but a little bit different. And so it's nice to be able to branch out into that robot. It gives you a little bit more flexibility and a little bit, I guess the best way to put it is it's able to give you a little bit more of dexterity intraoperatively, which is really nice when you're doing some of the harder, tougher cases.
So is it something that as soon as you joined Altman, you started learning how to use robotic surgery?
Yeah, so I knew actually probably about this time last year that I was coming here. And so Dr. Kelly, who's kind of the robotic guru who brought the robot to the area, at Altman at least, he was the one that got me really involved very quickly. And so I had some spare time even while I was still in my residency, and I started coming down here and training and doing some things on the robot so that I could hit the ground running when I started in August. So yeah, there is a little bit of time you have to spend on the robot, and then we you have to do a couple days of more formal training at their main surgical center. We went down to Atlanta. They have a site down there where you get to learn some tips and tricks from the folks down there that do a lot of the training stuff before you're able to do it on patients.
How close are we to have the robot not have assistance from a doctor?
I don't know, but I hope not.
Well, I actually saw this on the news the other night that this was the first surgery that the robot did without a physician along.
I've got too many kids to pay for, so I hope that's not too too far away, too soon anyway.
Gee whiz, I hadn't thought of that.
You're gonna put me out of a job here.
But I was thinking when I saw this on TV or somewhere, I can't remember, just a couple of days ago, and I thought, holy smokes. I'm in the room with a robot.
Now, as of right now, all I know is they take it's all us. The robot helps us a little in terms of the reading what we're doing, but it is our movements and the robot copies our movements. So
So how about this? We know that airline pilots learn how to fly a plane on a simulator. A test pilot. Is it similar for robotic surgery? How do you get trained on using a robotic tool?
Absolutely, good questions. So they're actually with the robot itself, there is a training program within it. And so there's some virtual reality kind of stuff that you can practice suturing, you can practice moving instruments, switching arms back and forth, which is good, but virtual reality only does you so much, even as good as it is. So then we also do what's called dry box stuff, where we actually dock the robot like it's a patient, but it's in a model. And then you're able to practice suturing on things like we did in medical school on foam or fake skin, and things like that. And then, especially when you go down to Atlanta, like I had mentioned, that's when you're actually practicing usually on a cadaver or some type of animal model, to practice some of the surgeries prior to getting clearance to do it on patients.
Interesting. Okay. All right, you're up, Dan.
Okay, so March is colorectal cancer month. Okay, I don't know where that one came from. Okay, that month, but anyway, what would you recommend for good colorectal health?
Well, and we'll probably touch base on it, but the biggest thing is diet and exercise, as all us doctors like to say, eating healthy and making sure your bowels are regular and things like that, whether that means fiber in your diet, but then also your cancer screenings is a big thing to make sure that you're up to date on all of that stuff.
Well, I would suspect we need to take a break here. Is that right, Brad?
Yep, we are about there.
You're listening to Health Matters with the Medicine Center Pharmacy. We'll be back in a few minutes. Welcome back to Health Matters with the Medicine Center Pharmacy. This morning, we are talking with Dr. Chase Beach from Altman General Surgery. We also want to note that we have flu vaccine, Moderna, and Janssen COVID vaccine available. Please stop by any of our stores to get vaccinated. No appointment is necessary.
All right,
Go
Doctor.
ahead.
Okay, we were talking about robotic surgery before the break. How are you positioned? I guess we've seen enough movies to think, are you wearing something? Do your arms fit in it? How does it look from your perspective and for what the patient might feel like?
Absolutely. Good question. So we're in the same room. So I'm within 5 to 10 feet of the patient. Even though I'm not scrubbed in at the patient's bedside, I am in there to place the ports, which we normally do, whether it's laparoscopic or robotic. And then once I help dock the robot, because there's actually a machine that has a bunch of arms that comes up to the patient, then that hooks up into the patient, we put in the instruments, and then at that point, then I go sit at the console, which controls the arms. So I'm within 5 to 10 feet tops, depending on the size of the room and the positioning of everything else in the room.
So are all of your patients out, shall we say? Because I'm thinking about this thing coming at me. Okay, if I'm not out, okay.
Yes.
All right. Here's this thing coming out with all these arms and all.
Yes. No, you're all the way out. No, for any laparoscopic or robotic surgery, we need the patient completely relaxed, because 90% of our what we need is visualization, right? For anything we're doing. And to do that, anytime we're doing things laparoscopically or robotically in the abdomen, we need to inflate your abdomen with air. We use carbon dioxide. And so to get that maximum visualization, we want you relaxed. So if you're coughing or kicking or pulling, or if you're having any signs of any pain or discomfort, those muscles are going to contract, which makes it tough on us to see what we're doing. So you are completely all the way out, no ifs, ands, or buts, or in between. So you're completely comfortable, unaware of what's going on, and before we even make that first incision.
So how many arms does this thing have?
Yeah, good. Yeah, so four, has four total. Depending on what we're doing, we don't use all of them. So,
Okay.
just as an example, for our, our inguinal or groin hernias, we usually only use three. Depending on the gallbladder, for our harder ones, sometimes we'll use four, sometimes we'll use three. For our bigger surgeries, hiatal hernias or colon surgeries, usually that means 4 arms.
Wow. Okay. Go ahead, Brad.
All right. So, how about risks or complications associated with surgery versus traditional surgery?
Yeah. Overall, they're about the same. Again, had a kind of like I mentioned prior, that the robot really just gives the surgeon an extra level of dexterity. And what I mean by this, and this is how I kind of like to explain to my patients actually, the biggest difference between laparoscopic versus robotic. The ports are similar in size, sometimes a little bit bigger for the robot, which doesn't, in millimeters, like sometimes the difference is 5 millimeters, sometimes with laparoscopic versus 8 millimeters for the robot, which, to you as a patient overall doesn't really change your pain very much, just those extra 3 millimeters. But the way to describe it is, think about if you were a mechanic, if you had a pair of pliers, you can open that jaw, open and shut, but you can't, if you're in a tight space, you can't bend that. You don't have a wrist on that instrument. And that's what the robot really gives us, is that we're able to, within that instrument, then give us a wrist and gives us 360 degrees of motion with that instrument, which for some other tighter spots and tougher cases can be really, really useful.
So I'm kind of thinking, you mentioned earlier in the program that you didn't have a lot of experience with robotic surgery till you came to Altman.
Correct.
So I'm guessing that means that you and all surgeons, for that matter, are trained the traditional way to do a surgery, but the robot can enhance the way you get things done and give you some more precision. Is that too generalized? Or
no, that's no, absolutely. And yeah, to your point, so doing all these cases that I do robotically now, I know how to do laparoscopically. So say for some reason the robot goes down or malfunctions or isn't available, because we only have 2 of them. I can do all of these procedures laparoscopically. The benefit is, again, I get that wrist, and there are a lot of instances where having that dexterity also allows me to help you with your pain, because I don't need to, if I'm doing this laparoscopically, let's say it's a hernia, for example. You just had one of these the other day where the robot was unavailable. It was an emergent case, and the gentleman had a groin hernia that was stuck, and we had to take him emergently. So I didn't really have many other options. To do that completely, to put things back where I had to, we have to use a tacker, which sounds uncomfortable, and it is a little uncomfortable. Those tacks are absorbable, but to put things back together, we tack some things to the abdominal wall to make sure everything stays put, and so that causes a little bit more pain. Now, if we were doing this robotically, I am able to suture those things back together, and because I can use that suture, it's a lot less painful for the patient, because they're not. Those tacks aren't into the abdominal wall. So there definitely are some benefits, especially when it comes to the hernia operations, in terms of post-op pain.
Does the robot suture?
It can, yeah. So I mean, I'm controlling the robot, but I'm able to put a needle and suture in there. And again, that's where that dexterity, having that wrist in there, is a big plus, because it can be kind of difficult to suture with those straight instruments sometimes, and curve the needle the way you want to.
Okay, so I'm not thinking that a robot can do that curved needles sewing. Is that?
It does, yeah. So
No
we're able
kidding.
to fit, again, that's why we use those little bit bigger trocars, that 8 millimeter that I was talking about, because we can fit the needles through there, as opposed to the 5 millimeters. So we can put the needle right through that, suture up what we need to suture, and then we pull the needles out when we're done.
I guess I'm thinking, after looking at my recent surgeries, I use staples. Can the robot do staples?
Internally, I guess we use clips sometimes. I wouldn't refer to them as staples, like you would normally think. But so for a gallbladder surgery example, that's somewhere where we use clips fairly often to clip both the duct that feeds the gallbladder and the artery. So we can use those there. And every once in a while, we'll use clips for, vessels or things like that if we're doing a colon surgery or something. So we can use clips but I wouldn't. Yeah, stapling is a little different animal. But
Yeah.
it will do. If you're talking about stapling, I guess for, let's say, a colon resection, for example, because normally when we're taking out part of your colon, we staple across the colon so that there's no leak and no one, to prevent any infection. So we can do that robotically as well.
That's amazing. I just think it's
Yeah.
amazing.
It's good stuff.
So, okay, you bought a robot for $1 million or whatever they cost. Okay, I don't
Yeah.
know what they cost. Do we get upgrades? I mean, or do we
In
have to
terms
buy
of
a new robot?
software,
Yeah, well,
yeah,
software and what the robot can do
yeah.
in a more sophisticated way. Maybe I don't know what I'm really saying here, but
No, yeah, no. So to answer your question, and again, I'm not a robotic rep, so I don't want to completely speak for them because obviously they know a little bit more about the upgrades. I believe they're on the third or fourth generation of robot now. So there are different types that can do a little bit different things in terms of the upgrades, like you're talking about. But they're always making upgrades to the instrumentation that we use, and that can work faster or quicker and do things a little bit better that makes it safer and better for us as well as for the patients.
Very interesting. Okay, time for our second break. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back. We're talking with Dr. Chase Beach, general surgeon with Altman General Surgery. We have a lot more to cover this morning, so let's get back to the show. Since I jumped out of order here, I think the next question is, you answered where you are while the robot's working.
Yeah.
I just think it's 5 feet away. It's amazing. So we talked about various types of surgery that you can do with a robot. Is there really any unusual surgeries that this robot would or could do?
I mean, right now, I think, it keeps expanding in terms of some of the stuff. Most of the general surgery stuff that we're going to be doing on a daily basis, we're already doing with it. So in terms of some of the new expanding robotic surgeries are probably outside of the general surgery practice, but we pretty much use it for most of our bigger intra-abdominal stuff as we see fit.
What about, ophthalmic surgeries and things like that? Is that where it's going, or don't we know yet?
That's definitely outside of my area of expertise, so I don't want to
No,
speak on that. I know they're doing a little bit more, at least for like thyroid and things like that, but I
yeah.
don't know how, some of this stuff always takes a little bit of time to really implement, even if it shows some benefit. The robot has been around for some time, and it's really now just starting to take off in terms of the general surgery world. But so it takes a little bit of time. Us doctors tend to be a little stubborn sometimes. We know how to do. I know, right? Surprising.
What do you mean?
We know how to do something, the way we've been doing it for 10, 15, 20 years. Trying to start that all over again, sometimes is a little bit hard to implement and to get really take hold. So but I'm sure that there'll be more and more as time goes on, that the robot will really be able to benefit other surgeons.
I was thinking about cataracts and lens replacement and all that sort of stuff, which
Yeah.
I've had that all done. So I'm thinking
Fair enough.
some of it is Medicare doesn't cover laser eye surgery for lens replacement, but they will cover scalpel. Okay, and I'm thinking, gee whiz, I don't want to scalpel my eye,
Yeah, I don't blame you.
So anyway, go ahead, Brad.
So how do you determine what surgery a patient needs, whether you're traditional or you're robotic? Are there qualifications or extenuating circumstances?
Yeah, absolutely. I mean, we try and take every patient's an individual, right? And so, let's just say, for example, a gallbladder. You come in with your typical gallbladder symptoms and pain in the right upper quadrant, nausea. And we say, okay, well, we both agree that we think you would benefit from a surgery. Okay, what are the next steps? And most of the time, and even every surgeon is a little bit different. Some people will say, I think doing this laparoscopic is just as good as robotic, and that's probably very true. Some people prefer to do the robot because they get a little, again, that dexterity. But at the end of the day, it's really depending on the patient. Have they had prior surgeries that would interfere with port placement for one or the other, because the ports are a little bit different location. And the last thing you want to do is go through some scar tissue, or go through, if there's something else in the way. The other things are, availability, like we just talked about with the prior patient that I had. Sometimes some patients will say, look, doc, I'm having so much trouble. They said they can't get me into the robot for another 2 weeks. I'm really struggling. They will say, well, we can just try and get you in laparoscopically, and I have a little bit more flexibility with that time frame. So it kind of just depends. But most of the time it's a discussion between the patient and the doc, trying to figure out what would benefit them the best. And the risks and benefits are similar for both, but again, those port placements can play a key, and timing can too.
How about, do all your colleagues in your practice perform robotic surgeries?
Yeah, every single one of them. So it makes it great, because there's not as much variability between all the 5 of us. We pretty similarly practice pretty heavily on the robotic side. But it just depends. Again, some docs will prefer to do one surgery laparoscopic over robotic. But again, that's to their kind of preference. And at the end of the day, that the risks and benefits are fairly similar.
You've touched a couple times on laparoscopic surgery in our program. Do you have anything else you want to add about the differences between robotic and laparoscopic, or have we covered that pretty well?
I feel like we covered it pretty well. And that's kind of the general spiel I give my patients that are asking similar questions. And a lot of the handouts that we give that we give out to patients in terms of expectations of pre-op and post-op and things like that will mostly touch base on the laparoscopic stuff. But overall they're pretty similar in terms of recovery and that type of thing. There are some nuanced differences depending on what kind of surgery you're getting, whether it's hernias or colon surgery or what. But overall, the difference to the patient in terms of post-op recovery and that kind of stuff are overall pretty minimal. Just depends on what you're getting done.
That's interesting. I wondered if you'd say that recovery times might be a little faster with robotic, given possibly smaller incisions or less invasive, but
yeah. But again, laparoscopic still has smaller incisions and still has those benefits in terms of post-op pain and post-op infection. The biggest thing it really comes down to is what you're getting done and what the options are. Like I touched on for the hernias, most of the time I try and tell people, I think the hernias are really where the robot can be pretty effective in terms of your post-op pain. Usually you have similar amount of incisions for the laparoscopy, but again, if we're talking about putting in a piece of mesh to reinforce that hernia once we fix it, which is pretty common, you either have to suture it in with the robot or tack it in if you're doing it laparoscopically. And so that's where I think really the benefits in terms of post-op pain, even though, like I said, those tacks are not permanent, the ones that we use, they can still hurt, and so if you're putting in 20 tacks versus suturing things, sometimes, those can be pretty painful.
A follow-up question to the recovery times are how many of the procedures you do every day are same day outpatient? Is that improving for patients not having to stay overnight at the hospital?
Oh, absolutely. I mean, even just the last, granted, I'm one of the younger guys, so some of my partners could probably better speak to really the transition that we've seen over the last 20 or 30 years. But gallbladder surgery, just as an example, used to be crazy to think that you would go home the same day after that surgery. And slowly over the past 30 or 40 years, that's really transitioned into you come in, you have your 4 incisions, you recover, and you go home that same day. Which is, really been a benefit, I think, to the patients as well as to the hospital system overall, and being able to get these patients home so that we're not keeping folks, and especially during this pandemic, keeping, taking up beds and nursing staff when everyone's a little overwhelmed and overworked, unfortunately.
In my experience with gallbladder surgery, well, I was in fact in the hospital for 3 or 4 days, as I recall.
Yeah.
And I went home and had to stay home for a week or longer. I had to wear an abdominal binder. Now, so you're going to do that gallbladder laparoscopy procedure. Do I have to go home with a binder, or am I pretty well held together?
You're usually just fine. And most of the time, what surgeons will say in terms of the binder, it's more of a patient comfort thing. It's not necessarily completely holding you together. It's more, sometimes people have more pain if those incisions and things are moving around, especially when
Sure.
you're up and moving, and especially if you're coughing. So it's nice to have that little bit of extra security to kind of brace yourself as you're moving around, especially with those bigger incisions like you had with that
Yeah,
open
like
gallbladder.
let's see.
Yeah, and we still do those every once in a while. We try to avoid it, but every once in a while, sometimes those gallbladders can be so infected we were unable to do it even with the robot or laparoscopically. And sometimes we still have to make that old school, 6-inch incision underneath that right rib cage.
Okay, scar tissue. Okay,
Yeah.
all right. In a large incision,
Mhm.
you're going to get some scar tissue because I know I got it, which hurts, or
Yeah.
whatever going forward. Okay. Um, so what about the robot? Okay, a smaller incision. And maybe we're not been around using that long enough to tell if we get any scar tissue down the road. What's the deal?
Yeah, it's similar to laparoscopy. Again, the incision difference usually isn't very much, but there's definitely, the smaller those incisions, the less chance of scar tissue. Unfortunately, the more messing around in your abdomen or wherever, the more scar tissues are going to be. So, it's definitely not a foolproof plan. But definitely the smaller the incisions, the less chance. And if you are going to get some scar tissue, usually it's a lot less compared to those larger open incisions, which makes it, less issue for the patient afterwards, even years down the line. And then if God forbid you need a second surgery, it also makes it easier on us if we have to go back in there, because we don't have to avoid those larger incisions where we could be running into,
Sure.
anything else that may be tied up in those scar tissues.
Okay, they told me that was common then to take your appendix out, as long as they were in there messing around and taking that gallbladder out. Is that common today?
No, we don't really do that anymore. They used to do that with hysterectomies as well, but they kind of over time realized that some people were having complications from taking out some of those normal appendix, and so we try not to do two things at once unless there's a very good reason. There's a couple still scenarios where we take out the appendix prophylactically to prevent any future stuff, but that's not nearly as common as it used to be.
Okay, so I come to you and I sit down in your office and you tell me we're going to do this surgery robotically. How many people freak out? Wait a minute, you're not going to be there?
I think it helps that Dr. Kelly and my other partners have done such a good job in the area about really making it much more mainstream. And I won't mention the hospital across the street, but I know they do some robotic stuff as well. And so I think in the area overall, it's, and I think that's probably common across the country, that it's becoming a lot more mainstream. A lot more surgeons are doing this in their everyday practice. So it's becoming a little bit less of, most people know someone through their, family or friend grapevine that has had at least something done robotically, which is nice. And so I think that helps to ease some of the anxiety.
It just seems like it all kind of popped on the scene, this robotic surgery, like it wasn't there and boom, all of a sudden it's there and everybody's doing it, which I thought was pretty amazing.
Yeah, no, it's really taken off.
So interesting. Huh. One more, Brad.
All right, well, we can talk about Colorectal Cancer Awareness Month here now. And before we got a little bit of time just before our last break, you mentioned earlier about what you recommend for good colorectal health. How important is diet and exercise to impact good colorectal health?
Yeah, and it's, just like with everything that us doctors tend to preach, that's the biggest thing. Prevention is the key. Rather than being reactive, you have to be proactive if you can help it. So yeah, a good healthy diet and exercise has multitudes of health benefits, including your risk of colon cancer.
Amazing.
Is it true that colorectal screenings can prevent colon cancer?
Absolutely. The way colon cancer, it's usually very slow growing. So most of the time they start off as a small polyp, And then slowly over time, some of the studies say a few years, 5, maybe 10, depending on the type of polyp that you're growing. So you have an ample amount of time usually to catch these polyps before they really turn into something and that turns into something that you need a bigger surgery or, God forbid, chemo, and all that stuff. And so it's much easier to catch these, again, like I said, proactive rather than reactive. If you can catch them early, it makes it a lot easier on the patient, it makes it a lot easier on us, and everybody wins in the end.
All right. Well, I think it's time for our last break.
Okay. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. Today we are talking with Dr. Chase Beach from Altman Surgery Center. Where are we, Brad?
All right. Well, let's talk about Cologuard, doctor. Is it is it as reliable as colorectal screenings?
So the nice thing is it's been around for a little bit. So the studies actually show that it is pretty reliable, and obviously, a lot easier because you can do it at home and send off your box and get some answers. At the end of the day, the nice thing is for the, if you're doing a colonoscopy, you can find it and treat it at the same time. So for example, if you have a Cologuard that comes back as, you may have something, you're a high risk patient, they come back as a positive, then their next step is going to be a colonoscopy. And so, as easy as it may be, it still is not the end treatment at the end of the day. And usually the nice thing about the colonoscopy is it diagnostic because it can find anything as well as treat at the same time. And, get rid of the polyp if that's all there is, or if there's, God forbid, something more concerning, they're usually able to take a biopsy.
So are we still on the 5-year thing every 5 years after age 50? I can't remember what the age is.
Yes. So actually the newer stuff are saying 45, that you should start at 45 for your colorectal screening, your colonoscopies or Cologuards, depending on what your family doc recommends based on your risks. Obviously, if you have any family history, then that pushes it even earlier because we usually like to start that with 10 years before any family member. So if you had a brother that was 45, then you should probably start thinking about looking at, in your mid 30s to prevent any future issues. But yeah, that number is slowly creeping down. And the studies are showing that the risk of an issue from a colonoscopy is low enough, but the benefits are really there, especially if you can catch some of these things early rather than late.
Most people fear the colonoscopy. Oh my gosh. I'm going to have this. Oh my God. You know what they do? A lot of them go out and have a huge meal. Okay. The day before, I was thinking, oh, wait a minute.
Yeah, doesn't really help the surgeon or the GI doc that's doing it, unfortunately.
Okay, I just went through the drive-through. I had 2 hamburgers, and I even got one for my dog because tomorrow I'm gonna have a colonoscopy. I'm thinking, wait a minute.
Follow the instructions, please. It helps us. It helps you.
Yes.
I can't, because every once in a while, if the prep's not good, then we tell you have to do a second time, which again is not fun. The first time around. Yeah. But a lot of people, especially folks that have had a prior or heard some horror stories, the sedation that we give for these has really improved on how we do some of these. Some people you'll talk to and say, Doc, I was awake during that whole time. I saw everything. It was miserable. I had, some discomfort, which doesn't, is getting less and less, but we, the medicines that we're given for that to make you comfortable during that really has changed. And so some of those folks that got one 20 some years ago and were like, I'm never getting another one. That was the most miserable experience. I don't know why anyone would want to do that again. We're not having those anymore. So I really encourage folks, if you're kind of on the fence, at least meet with the GI doc. And if those are your concerns, you can at least go through those with them. But like I said, that the sedation really is a lot better than it used to be. And so most of the thing people complain about is the prep, which, as you were alluding to, is not the most comfortable. And but again, 24 hours of staying in the house and doing the prep is a lot better than getting some big surgery or having colon cancer.
Yeah, for sure. Okay, very interesting.
So, doctor, how can our listeners reach out to you or find out more about you?
Yeah, so I am obviously on the Altman website, which is probably the easiest way. If you go to altman.org, there's a find a physician link. You could probably um, search me that way, or just type in, general surgery, and me and my partner should pop right up for you.
I'm guessing that most of your patients end up being referrals from primary care doctors. Am I mistaken, or?
Yeah, so it's actually probably, I would say maybe 70-30 mix. So most of them come from a primary care, but we do take patients who feel like they need to be seen if they have a hernia or gallbladder problems. We don't need a referral for you to come to the office. And so you're able to just reach and call our office and find the surgeon that you want, or whatever time works for best. Because we've got, like I said, 5 surgeons at various locations between main campus and Orville and Massillon and Dover, trying to help the community as best we can.
All right. Is there anything, you've clearly are probably the closest being out of school, given your education level. What are you excited about that's coming in general surgery? Are there new techniques or new things on the horizon that you are excited to implement, or you're looking forward to making a patient experience better?
Yeah, I mean, for me, I know we touched base on it a lot. Really has been my ability to implement the robot stuff, and being able to offer some of that to my patients has been really great for me. Has really changed how I've approached some of my patients, especially from a hernia and gallbladder standpoint. And I think it's really been a benefit to both me and my patients. In terms of what else is coming down the pipeline, I think that's the biggest thing, at least from my standpoint, that I'm aware of. I mean, there's always new studies going on out there. Breast cancer stuff is always changing, so that's always a hot topic, and so there's always a lot, big research stuff on that standpoint in terms of lymph nodes and treatments. But from a surgery side of things, I think as of right now, there's not a whole lot that's too big, that's changing. I know that at least the last biggest thing that they were talking about for a little bit was those magnets they were using for some reflux disease, which I don't know how well those have been doing. I've never done one. I've never seen one done, but outside of the robot, that was the topic for a minute, but that's kind of faded away. And I don't know.
What do you mean? I don't understand what you mean.
Yeah, so they I believe it was Lynx, LINX. For folks that had a lot of reflux, they were trying to figure out a way to prevent reflux of stomach acid up into your esophagus, up into your food pipe, causing some of those reflux symptoms. And so they had developed basically a wrap of magnets that would go around your esophagus prior, so that way your food would slip through, but then nothing else would slip back up. Traditionally, if we're talking about a surgical repair for that, we would take the top of your stomach and wrap it around the top of your esophagus to kind of create a little bit tighter wrap around that esophagus to prevent anything from going back up. So they're trying to find a better way to do that.
What about hiatal hernia surgery? That was big time years ago.
Yeah.
Don't hear much about it. Is that not being done any longer?
No, it is. Good question. The reason you don't hear as much about it is because the medicines have done so well. The PPIs, we call them, omeprazole, pantoprazole. A lot of folks that were having issues with that, the medications have really done those patients a good service. So we do some of those, just not as frequently maybe as you heard about 10 years ago. But there are still some patients that qualify for that repair.
We used to sell tons of antacid. I mean, people would buy cases of liquid antacid.
Yeah.
Just and Mylanta and some of the other products out there. I think, holy smokes! What do you guys do with all this stuff?
Yeah, now it's just one pill a day, maybe twice a day with those.
I know, yeah,
the pantoprazoles, and they're good to go with their whatever they want to eat.
I think we're out of time, Doctor. We really enjoyed talking with you today.
I appreciate it.
Thank to our guest, Dr. Chase Beach, General Surgeon with Altman General Surgery. We'd like to remind our listeners, if you suspect you have a medical issue, please contact your healthcare provider. Thanks to Studio Arts and Glass, and of course, our technical producer, Billy Beebe, and Genure Estates. And as always, we thank you, listeners, for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week. We'll see you right here next week on WHBC.